Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Gretchen Winter.
On behalf of Chest, I would like to welcome you to this Chest Journal podcast. My name is Dr. Gretchen Winter, your Chest podcast moderator. So thank you all for joining us today for an interesting discussion with Dr. Andrea Cortegiani and Dr. Mariachiara Ippolito. They and their colleagues wrote an article in the Chest Journal, Association between Spontaneous Breathing Trial Methods and Reintubation in Adult Critically Ill Patients, a systematic review and network meta-analysis of randomized controlled trials. Dr. Cortegiani is an associate professor of anesthesiology and intensive care medicine at the University of Palermo in Italy. He is a consultant at the University Hospital Policlinico Paolo Giaccone and is the head of the Italian Society of Anesthesiology and Critical Care Scientific Committee, CRT, their systematic review group. Dr. Mariachiara Ippolito is an assistant professor of anesthesiology and intensive care medicine at the University of Palermo in Italy and a consultant at the same hospital. She is also a member of the CRT systematic review group. So thank you both so much for joining us today.
Thank you for inviting us. I'm very happy to be here.
Absolutely happy to be here to discuss our article.
Well, let's jump right in. You guys looked at whether different modes of spontaneous breathing trials compared to T-tube trials were associated with different risks of reintubation in critically ill patients. So what prompted you guys to ask that question?
Because spontaneous breathing trial is a practice for everyday clinical practice in every ICU all over the world, and the evidence supporting the effectiveness of one of the methods in terms of which method is the best is scarce and limited. So a lot of data, a lot of trials, but actually we don't know which is the best spontaneous breathing trial method to assess if our patients are ready to be extubated or not with a low risk of reintubation. And network meta-analysis are nowadays the best statistical methods for evidence synthesis when you have more than two interventions towards the same outcome. So we decided to design this systematic review and network meta-analysis to answer the question, which is the best method for the spontaneous breathing trial in critically ill patients.
So before you guys did this study, what did we know about spontaneous breathing trials and reintubation risk? Are there currently recommended expert guidelines?
Well, prior to our study, the topic had already received wide interest and many randomized controlled trials had been conducted. But the vast majority of the studies had compared pressure support ventilation to TP's SBT. However, there is still no clear evidence on the best method able to reduce the risk of reintubation. Guidelines exist on the topic. One of the latest is clinical practice guidelines made by the American College of Chest Physicians together with the American Thoracic Society and published in 2017 in Chest. These guidelines supported the use of low respiratory pressure support for SBT, but we also found that there are novel methods and decided to further explore the topic with an additional analysis.
So then can you please tell us more about your study design?
We conducted a systematic review and Bayesian network meta-analysis of randomized controlled trial investigating the effect of different spontaneous breathing trial methods on the outcome of reintubation. And we surveyed 4 major databases from the inception to 26th of January 2024. And we used current methodology to assess the effect sites of each of the intervention, and we also assess the certainty of the evidence according to the methodology used under the GRADE method. And we included 22 randomized control trials for a total of nearly 6,000 patients. And as I said, we performed a network meta-analysis, and we were able to create 9 nodes. Nodes means interventions, and 13 direct pairwise comparisons among the interventions. And I would like to underline that the vast majority of the patients that are included in this meta-analysis are randomized in trials that compare T-tube and pressure support ventilation with positive and expiratory pressure.
So, Dr. Ippolito, your primary outcome was the risk of reintubation. What did you find regarding that risk with different forms of spontaneous breathing trials?
The outcome of reintubation was reported in 20 trials included in our meta-analysis. We identified 9 different interventions and conducted a comparison among these. High-flow oxygen spontaneous breathing trials were associated with the highest probability of being the best intervention for reducing the risk of early reintubation, according to the surface under the cumulative ranking curve. It was also associated with significantly lower risk of reintubation compared to T-tube.
And Dr. Cortegiani, you guys looked at several other secondary outcomes, including extubation after the first spontaneous breathing trial, overall duration of mechanical ventilation, ICU mortality, and ICU length of stay. So what did you find with regards to those outcomes?
Indeed, our analysis did not show any discernible effect of interventions on these secondary outcomes. And the reason is that statistically, the power of this analysis in terms of imprecision was high. So the most robust finding is related to the primary outcome. Of course, this is the statistical reason for the response to your question regarding the secondary outcomes. Indeed, it is also probable that the association between the link between an effect on a reintubation and these other important patient-centered secondary outcomes is still unclear. So just to summarize, most robust results according to our analysis is on reintubation outcome, that is our primary outcome. And for the others, we were not able to see any discernible effect, mainly due to imprecision of the results.
Understood. So your findings show a possible benefit to high flow oxygen that was not seen in prior meta-analysis. What do you think might contribute to that?
Thank you for this question. Our study indeed is the first identifying high-flow oxygen SBT as the one method with the highest probability of being the best intervention in reducing the risk of reintubation. An effect was already seen in the direct comparison with TPs or T-tube in previous meta-analysis, but we believe that the network meta-analysis design allowed us for a comprehensive comparison among all the intervention, highlighting the potential role of high-flow SBT.
And what are some of the limitations of your study and the available evidence?
I would start on the limitation of the available evidence, because most of the included randomized control trial were judged at high risk of bias, precisely 18 out of 23 randomized control trial. And so we downgraded the certainty of the evidence mostly for high risk assigned to the domain measurement of the outcome. This is an important point because reintubation is a critical outcome, but to reintubate a patient is a clinical decision. So most of the time, the trials in the trials paper, we were not able to clearly see the criteria adopted by the clinicians to decide if there is the need for reintubation or not. So we started judging this domain at least at moderate risk of bias, but when no criteria at all or poorly defined criteria were reported, we decided to assign high risk of bias. This is the first and, in my opinion, most important limitation of available evidence. Other limitations are related to the fact that we were not able to analyze an effect of comorbidities of a patient, cardiorespiratory functions, age, type of admission on the findings. But also, we were not able to stratify the results according to characteristics of the spontaneous breathing trial, for example, the time, the duration, level of pressure support, or flow rate. So actually, we don't know if these variables can impact on the effect size for reintubation that we were able to calculate. And another important limitation is, in my opinion, is not a limitation per se, but is a way to do the Bayesian network meta-analysis, because we decided to do the generalized linear model for calculating our results were based on a not informative prior. So under the Bayesian point of view, that means that the actual data influenced the posterior probability. But we also try to change the prior in an optimistic or pessimistic prior as descriptivity we reported in the supplementary material. And we saw that the results changed a lot. But at the beginning, there was no reason to decide which type of prior, apart from the not informative, should be selected. So in our opinion, that's correct. But more data in the future can change the prior distribution and can also influence the posterior probability, namely our results.
So what unique findings does your study add to the literature? Like, what do we know now that we didn't before this study?
So as discussed today, we know that high-flow oxygen SBT is probably associated with a lower risk of reintubation in comparison with other SBT methods in critically ill patients.
Great. And what do we see as future steps for this research? Where do you go from here?
Well, the merit of our analysis is to provide this important background for future research, because today we know that we should further study high-flow SBT with further high-quality trials that should be performed to confirm our results. And also physiological studies should explore the mechanism behind this estimated benefit of applying high-flow through an endotracheal tube during an SBT.
Very interesting. So if you guys could give our listeners a closing thought on what you've learned from this research, like what do you want them to take away from this discussion? Dr. Cortegiani?
The available evidence among the interventions to perform an SBT underline that actually nowadays high-flow nasal oxygen seems to be top ranked among these interventions. Available evidence has important limitations, and probably we should also see these results also in light of the other type of respiratory support that we apply after the extubation. So available evidence nowadays on SBT after 30 years of research seems to say this. But I think that further research, as Mariachiara said, will shed lights on how high-flow act and how we should adopt non-invasive respiratory support after the extubation to maximize the results in terms of lowering the risk of reintubation.
And Dr. Ippolito?
Yes, I would like just to add, let's further investigate on the role of high-flow SBT and on the mechanism behind this estimated effect. I also would like to give credit to the entire group of the co-authors, especially to those taking part to the systematic review group, and to my co-first author, Salvatore Sardo, my colleague.
Well, a big thank you to both Dr. Cortegiani and Dr. Ippolito for a great conversation. And of course, a big thank you to our CHESS community for joining us. I'm Gretchen Winter, and this is a CHESS podcast. Until next time.